I think we have a few more CPAC members that are due back. When you get back, please turn on your camera, CPAC members, so I'll know you're here. Okay, I think everyone's here. So welcome back from lunch, everyone. We are now to the voting section of our day. I'll read the first question and then you guys can raise your hands if you have questions and we will ask the appropriate people. Okay, so first of all, I guess we need to make sure that you have the voting, that your voting situation works. So the app is, or the Slido is on the right. So be sure and get that going. Let's see, make sure I can do that too. Okay, so for the first question, for children aged 2 to 12 years with SMA type 2 or 3, is the currently available evidence adequate to demonstrate that the net health benefit of apitegromab is, in addition to standard care, risdiplam or nusinersen, is greater than that of the standard of care alone? So this is the SMA type 2 population, by and large, the population that is identified clinically, not through newborn screening. And so I guess, Jeff, if you would please direct us to, or remind us of the clinical evidence that you presented earlier.
Yeah, so the clinical evidence, the evidence summary is table 4, which is on page 7. That's the benefits. Sorry, I need to grab it myself. Hold that up screen here. And I mean, the key elements are the Hammersmith, the improvement of 0.6 points versus a decline of 1.2. And then the percentages that had at least a 3-point improvement, and the percentages who had at least stability or better. And then the harms are summarized on page 10, table 6. And here the real big difference is the absolute difference in serious adverse events, which most people consider a 10% absolute difference to be, concerning, substantial. Though there's always the possibility of chance here. And I just wanted to, I mean, we talked about this a little bit. Really helpful to have the experts with context. They chose a patient population that was non-ambulatory and that had a Hammersmith scale between 10 and 45. Remember, this is a 66-point scale. So they specifically excluded patients with a Hammersmith less than 10 or greater than 45, so that they had the highest chance of being able to detect an improvement in function by the scale. And we gave it a PI in part because of, the balance of net benefits and harms was a little uncertain, and we have one study with 1-year follow-up and a modest size when you compare it to like cardiovascular disease, though, you have to keep in your heads that this is a rare disease, so challenging to study in large populations.
Could you comment on how you think about, if we take the 3-point minimal important difference, and the difference here was 1.8 points overall, yet 17.9% more people absolutely had a 3-point improvement. So can you describe how you think about that? Despite they didn't reach the mean, how do you think about it?
I mean, that's why I presented it both ways, and including the 0 point. I mean, yeah, averages hide benefits that some patients get. That also means some people get no benefit at all. But we want to highlight the fact that some patients had a pretty substantial benefit, and as we've heard from the experts and the clinical community, they value just stability. They want to make sure they're not getting worse. So that 13% absolute improvement in the number of people who remain stable over a year, patients in the will certainly view that as clinically important and meaningful. Um,
Okay, thank you. David, did you want to comment on that, on my question at all?
Yeah, just in terms of thinking about minimal clinically important differences, we often get a concern from manufacturers that we're applying it to averages when it's really a patient by patient measure. And that's not completely unfair, and we don't always have patient by patient answers to that. And I've said sometimes when this has come up, if you have a number that's less than the MCID, you can guess that less than half of patients were likely to have hit the MCID, assuming that things are sort of on a normal distribution. And that's what you're seeing here, because we actually have the patient by patient numbers. We see that about 30% of patients, less than half, got to that MCID, substantially less than half. Some on placebo got to it. So I would look more personally at the patient by patient numbers when thinking about the MCID. I'd say, look, as you just said, 17 or 18% more people got to an MCID with the therapy than without. I think that's the more fair way to look at the numbers than applying the MCID to the average, which is an aggregate number. Still, most people didn't get to the MCID.
Great, thank you. Bijan, what's your question?
Yeah, Dr. Tice, my question is about the serious adverse events. So it is basically about 20 differences, 20% versus 10%. And then when they categorize it, it is two of them, like, the dehydration and what's the other one, pneumonia. So they add up to like only about 9%. Just curious as to what are the other serious adverse events that are like, in the 10, rest of the 10%.
I'd have to go back and look. I can't remember. There was nothing that stood out as remarkably different between the two. I can have Dimitri check that for me, and we can get that. Maybe if we hold the answer for a minute, we can come back to that in a few minutes. I'm sorry, I don't have that at the tip of my tongue.
I do think that the Scholar Rock argument that incidence figure is within the range of things you see in other trials is relevant. More interesting is why they had so few in the placebos, because that number is not at all surprising.
The flip side, you could argue it maybe they picked patients who actually are a little healthier somehow than other populations that have been studied in this disease, and that the background therapy is actually enough. We just don't know it. I mean, that's why I don't want to focus just on those specific. I think the difference in overall serious adverse events is 10% is a pretty large absolute difference.
Okay, thank you. Brad.
And this may be a question addressed to David or maybe others at ICER. So in the report, this condition, and I think appropriately so, is identified as an ultra-rare disease. And there's I want to know if they could walk us through ICER's framework for the evidentiary standards when they encounter an ultra-rare disease like SMA.
Sure. The evidentiary standards don't change just because, I've described this in other circumstances, such as within grade, as Reem's aware, as we don't grade on a curve. But we do acknowledge, as Jeff just did and shows up in the report, that it may be hard to generate high quality evidence in some circumstances, and that's just reality. That said, the disease modifying therapies for SMA in our 2017 report included nusinersen, which had a randomized trial where we gave it an A rating. So you were able to get to an A rating in this ultra rare condition. And the gene therapy, Zolgensma, which had, depending upon how you counted it, 12 or 15 patients in an uncontrolled situation that also got to an A rating because of the spectacularly obvious fact that the drug was incredible. Both of these. The Spinraza could have also had an uncontrolled trial and gotten the same results. So yeah, in ultra rare diseases, sometimes it can be hard to generate high quality evidence, but we've had a number of circumstances where a therapy for a severe disease of infants or young children gets a very high rating because of how clear it is that it has benefits that far outweigh any harms.
All right. I'm not grading on a curve. Got it. Thanks.
Don?
Yeah, well, my friend Tim Wiltz isn't here, and I don't claim to be speaking for him, but I think he would probably share my thoughts. I guess the first question was already sort of answered relative to the magnitude of the deltas between the lower baseline scores and the higher baseline scores. So that's an unanswered question, but I think it's important. And then secondly, and maybe you got at this obliquely, but this, how do we qualitatively, not quantitatively, I'm trying to reconcile the placebo group 12% improvement in my thinking. The N is trending me towards thinking it's insufficient information, but it'd be helpful if you provided any additional insights about that.
So can I just ask, Donna, are you concerned that the muscle benefits, are you not believing that they're there, or
No,
just
no. I'm just a little, I guess, since it's, I guess it's the placebo effect is related to the one drug, not the baseline, right? Is that what I just wanted to be sure I remembered that. I'm not questioning that the differences are there. I'm just asking about the 12% placebo effect. That's all.
I suspect that, there's some random variation going on from baseline over time, and children are getting older and lots of things could have caused small differences in that. But,
Right.
I mean,
So
we're not seeing
it's not
huge numbers,
insubstantial,
but,
that's all. So
but it does
that's fine.
seem like at least it seems to me on the benefit side that the drug works some.
Well, I think I agree with you. I mean, I'm just trying to balance that mindset in my thinking. That's all.
Yeah, could be a placebo effect, could be, a little bit of regression to the mean, maybe, though that maybe doesn't apply here because we didn't have quite a high threshold that we were reaching for. I think there's just, just was with any measure, like even cholesterol or bone mineral density, there's a coefficient of variation. You measure things again, you get a different answer. Some people go up, some people go down when you have a threshold. Some people will be above that threshold, and it probably reflects that plus a little bit of placebo effect.
Okay.
And maybe, as Dr. Crawford said, some patients had a really bad day the day they came in and weren't very cooperative, and when we reassessed them at a year, that it was a better day, and they got a better score just because they were more cooperative.
Kurt, did you have a question?
Yeah, I had a question. So this voting question is about pooled results of the 10 milligram and the 20 milligram per kilo. And the 10 milligram per kilo actually had a little bit better results, probably not clinically significant. How about the pneumonia incidence? Do we know that? Was it higher with the 20 milligram per kilo versus the 10 milligram per kilo, or not?
Yeah, I don't believe so. I think that's part of the problem. We don't have this publication. We probably don't have all the SAEs reported, so I may not be able to get at that. We highlighted the ones that were really different. So, and I think we just don't have that. I think Dr. Crawford alluded to, I think some modeling studies suggested actually a 10 milligram dose was probably the right dose. And there's some data that too much myostatin is counterproductive. So 10 milligrams may be the sweet spot. But it's a little speculation, I think.
So the modeling data suggested 10 milligrams, and the FDA required that they have 2 tiers. So they added the previous 20. there's this internal control when you bind pre-myostatin with apitegromab. It's released from the muscle and can be measured, and so you have this intermediate we could call it a biomarker of efficacy, and it was identical between 10 and 20, suggesting, just as their modeling was, that 20 was that they'd saturated the benefit at 10. So that's how I think it's best to interpret the difference in the clinical the value between the two. They're very small.
Okay, I've seen some activity on the chat that I wanted to give those people an opportunity to bring it forward now before we vote, if you'd like. David or
Yeah,
Portia?
sure. Yeah, I'm just, my major struggle is really kind of placebo groups, and then what happens to those groups because they have a net decline in functions, but also at the same time they reported like the no severe adverse event, particularly pneumonia and dehydration. So again, this could be very small sample, could be like due to the chance that kind of out of the control. To me, like that, I'm more inclined to that aspect, but still kind of understanding, is there any relationship between like the net declines in the function versus like the no SEAEs, whether clinically or biologically? That's just like to hear some thoughts from whether the experts, clinical or patient expert, things like that could be possible, consistent with your observations, or maybe just due to like pure chance.
Anyone else? Would anybody else like to make a comment before we vote? Rachel?
Just a very small one. The previous slide sort of asked whether it said that the population was children aged 2 to 12 with SMA type 2 or 3. To clarify, we're really here focused on the Sapphire trial. And so by definition, these are also children for whom Zolgensma has been excluded, right? Children who have not been treated with that. I just think a lot of us, it sounds like, are having difficulty extrapolating the results to different populations of patients because the results might be so different in different groups. And I just wanted to flag that maybe slight addition to the way that the population is described.
I think that you're accurate in what you stated. Portia?
I would be interested to know if the pneumonia that came about in that cohort was with the children who had lower copy numbers. I think that pneumonia is very prevalent in the SMA community, as we know, and I'd be very surprised if that had anything to do with the apitegromab. I think it's probably just chance from what I know about families.
It's a very good question. Without the publication or any subgroup analysis, we can't know that yet. Hopefully we will be able to in the future. Reem?
Can I ask from a timing standpoint, this paper is definitely going to be published by August 13, if not released before then. I don't know if that matters in terms of your timing.
I think we have to have the vote today, unfortunately.
Yeah.
We always update, it'll be put into context, and eventually the models actually are available online to those on subscription, so they can be rerun by interested people.
Reem?
I wanted to just kind of explicitly discuss, to me, despite all the challenges and limitations, and Rachel nicely summarized some of them just a minute ago, and I'm very appreciative that the data was presented overall, but also the proportion of people who achieved the 3-point and the proportion who did not change. To me, this piece of evidence is what is, directing me in one way versus the other. And I just want to say, and I know this likely and maybe a point for later discussion with the policy roundtable, but this makes me wonder if there will be any role or thoughts about, let's try this. And there is a good proportion of of patients who are actually going to have substantive or clinically meaningful change, even based on the data that we have, and some that maybe won't. I think the big challenge is, how do you know that this was not, even if they didn't improve, that it was not slowing considerably? What would have been the worsening if they have not received it? So I am aware of the limitation, but I think this is something that we're going to have to think about and hopefully discuss later today. So I just kind of wanted to share with everybody how I'm thinking about this.
David?
I just wanted to answer on something Rachel said, just to know one of the reasons we didn't restrict who we were talking about in the way you were picturing is that Zolgensma now has an intrathecal form that has been studied, the goal of which is to be able to administer it to older, larger children. And so we're going to be in the situation probably a year or two from now where some people have received that as their background therapy and who might benefit from the people who are type 2 and 3 getting Zolgensma instead of one of the SMN2 therapies to stabilize them, and then they might get apitegromab on top of that. And presumably, I think our expectation would be that apitegromab would work identically in that situation. So even though right now it is restricted, it probably won't be restricted that way 2 years from now.
Yeah, and I'm very sorry to respond. My concern is really about the timing, right? The timing when treatment is started. So for patients who start it a lot later versus patients who start it soon after birth, it sounds like there's a big difference. And in the Sapphire trial, it was more patients who had started it later.
Yes, no, absolutely. But it will also be Zolgensma started later once it's okay to give it later.
Jeff?
So I just wanted to come back to the chance phenomenon. So we have 10% absolute difference in serious adverse events, and we have a 13% absolute difference in stability or improvement. They're on the same order. If you worry about chance causing one, you could worry about chance causing the other. Again, highlighting why we thought there was substantial uncertainty here.
Thank you for that. Okay, everyone cast your vote. So we had 8 no votes and 5 yes votes. That's Any discussion on that? Do we want to move on? Okay, we'll move on. Next question then. For the population with SMA previously treated with onasemnogene abiparvovec, is the currently available evidence adequate to demonstrate that the net health benefit of risdiplam is greater than that of no additional treatment?
Sorry, these next two questions, background therapy of gene therapy, everybody's gotten gene therapy. Now they're adding additional SMN-directed therapy, the first being risdiplam. The benefits are for risdiplam are on page 8. Sure I have the right thing. And so have this a case series of 20 children, and you saw improvements in feeding, in swallowing, and in 9 points in the jewelfish study, I'm sorry, in 9 patients in the jewelfish study, you also saw a 6-point increase in the motor function scales, including the Hammersmith. So over about 2 years, 104 weeks. So small study, 9 patients with data, but with a 6-point increase on a number of scales, including the Hammersmith. And then harms are on page 11. We didn't go through in detail, but there's fever, diarrhea, rash, ulcers, arthralgias, but that were all more common in the risdiplam group than the placebo group than background therapy, but generally tolerable. They weren't serious adverse events, leading to patient stopping therapy in most cases.
David?
So just for context, I think most of you have this, but the gene therapy is intended as a one-time therapy. It's about $2 million. And then we're talking about adding on to that therapies that are very expensive, many hundreds of thousands of dollars per year that may or may not be providing a benefit. And so this is a big deal question. In the US, a lot of children are being treated with a second therapy. And I'd be really interested in hearing from Drs. Crawford and McMillan, whether how convinced are you one direction or the other that adding on these second therapies is helpful? Because for us, it's been hard to know. We've heard some people say they're very convinced that something good is happening, others not. I'd be fascinated to hear what you guys think.
So I need to be convinced. I'm not certain that we haven't saturated the benefit to be had with the first therapy. And the problem is that all of these are unblinded studies, and kids continuously gain after any one of these therapies. And so if your child stalls out some and you're not happy with it, so you start another drug, anything that is gained after that point is attributed to the second drug rather than to the underlying tendency of kids to gain at a stuttering course. So there's a real selection bias in people who went into those trials, people who were unhappy that they hadn't seen what they wanted to. So I want science, and I think there's some surrogate measures that would be very useful, and the surrogate measures are not being done.
I agree completely. And I would say that for the odd patient that has had an add-on therapy after gene replacement therapy, it's very rare for that to happen in Canada because largely it's not approved by public payers and certainly not private payers. It's really difficult, even in the natural history, to be able to differentiate improvement due to normal physiological hypertrophy of muscle that's associated, with growth in the first few years of age, from potential benefit from the add-on drug. It's really difficult to tease the two out.
So there's one sort of background thing that's worth mentioning is that all of these therapies, we have not made anybody with the DMT, with the disease-modifying therapies, we never make anybody better. We stop degeneration at a time when kids are naturally doing more things. And so the expectation is that kids are going to slowly improve just because they're growing older and gaining skills.
Which is very different from the situation of untreated kids who would continue to lose and be expected to get worse. These have gotten disease-modifying therapy, so they should be able to improve over time. So it's a very different situation from the untreated case where we were 10 years ago.
As well as the older children in the apitegromab studies who were receiving DMT, but now are at age where they start to accumulate complications of weakness. And so I think that might be responsible for some of the decline that we saw in the placebos that you didn't see in the treatment group.
Bijan?
Yeah, do we know like the gap in the completion of the gene therapy and the initiation of the SMN targeted therapy? I mean, does it make a difference between like how much was the difference between when they completed the initial gene therapy and then when they started the other therapies, add-on therapy? So I guess does it make a difference in terms of outcome?
So the next question is about nusinersen, and they did at least divide it up with the age at which they started the second therapy. And there was nominally a little bit more of a gain in those who started before 9 months compared to those who started after 9 months. But again, very small numbers, you know, different patients. Unclear whether that's just selection bias, something different about the trajectory of younger kids versus older kids, or whether you really get that benefit by the earlier you start, the better. I think it's, I'll let the other experts weigh in, but that's my read of the literature.
And these were referred patients who were not happy with the first one.
And I think it's important just to remember the normal natural history of muscle fibers. So even SMA aside, babies have muscle fibers that are about 15 microns in diameter. And over the first 2 to 3 years of life, it triples in diameter to about 50. So with that increase in the diameter of muscle fibers, there's also associated improvements in strength. So now if we bring it back to the SMA model, even in some of the pre-symptomatic patients, they may have had some loss of motor neurons and atrophy of muscle fibers. The ones that are still viable and healthy will continue to undergo that normal physiological hypertrophy as that child ages and grows. So if a second disease modifying therapy is started earlier, is that just the normal hypertrophy of muscle fiber? I think that's really the argument, I would say, or the challenge, is to be able to differentiate that from, any potential additional stabilizing effect from a second drug.
Any other questions? Okay. Everyone cast your votes. Okay, 1 yes, 12 no. Okay, thank you. We'll go to the next question. The next question is similar to the previous question. For people with SMA previously treated with onasemnogene abiprubart, is the currently available evidence adequate to demonstrate that the net health benefit, this time of nusinersen, is greater than that of no additional treatment?
So here the benefits are on 7 and 8, and it's sort of what we said. This is the one where you have a population treated before 9 months, population treated after 9 months. You see a fairly substantial gain in this subscale of the Hammersmith that's used for younger children, 8.7 points for those who started treatment before the age of 9 months, and 6.9 points in those started later. Small ends. It's 21 patients in is that right? Why do I think it's different? No, 21 patients in one cohort and 13 in the other. And then the harms are, this is the therapy where we're doing lumbar puncture. We have to do intrathecal delivery of the drug. So you do have more potential harms here, and it's a bigger deal. So that's why we gave this a PI. There was still promise from these numbers, but also the possibility of net harm if we're really not doing any benefit, as we heard from the experts, where we think there is still some uncertainty about this. Yeah, again, because of these are young kids who are growing, and hard to tease apart, is this a new drug effect or just natural improvements with aging.
Any further questions? Okay, everyone cast your vote. We're like in one person, double check to make sure. There we go. Okay, thank you. Okay. 1 yes, 12 no. And then the next question. Thank you. For clinically pre-symptomatic infants with SMA, is the current currently available evidence adequate to distinguish the net health benefit among nusinersen, gene therapy, and risdiplam as first-line therapy?
So here we're talking about the situation we have in the United States, luckily, where we're doing newborn screening. The baby doesn't have any symptoms yet, or minimal, not that we can pick up easily. And you have to choose between the three available disease-modifying therapies. So the comparative benefits are table 5, which is on page 9. And then we sort of heard about the harms of all three therapies other than gene therapy. They're listed on pages 10 through 11. And I realize that this table is a little obscure, so just to orient you, I'm sorry, table 5 is a little obscure. So the nurture study, that's nusinersen. Again, these are kids who probably would have died by the age of 2. They're all surviving. They're all breathing without a ventilator. The SPRINT study is the gene therapy, Zolgensma. Same thing. And then Rainbow Fish is the risdiplam treated patients as first-line therapy. And so you see, all of them have this, are saving the lives of these kids that would have died before and preventing the terrible degeneration of the neuromuscular system. And then, unfortunately, a lot of the scales are not measured in all of the different patients, but you can see in the Hammersmith 2, the one for the younger kids, you get similar benefits in terms of independent standing and so on across the three therapies. So reasonably similar outcomes, some differences. We heard maybe the swallowing speech bulbar things are a little different, but very different populations. Really hard to compare across these and really have any confidence that the differences are real. There are real differences in the potential harms: gene therapy, hepatitis, severe reactions to the vector delivery system, long-term potential for oncogenesis from insertion of the gene, and then intrathecal therapy with nusinersen and an oral therapy with risdiplam. So clear differences in adverse effects from harms from the route of delivery, but in my assessment, our assessment in writing the report, substantial uncertainty about any differences in the outcomes with the three therapies. And you already heard from the experts that they feel like potentially you're saturating all the benefit with any of these. They may be equally effective, but it's really hard to know without really good comparative studies. Ideally, randomized trials. I know Dr. Rind would prefer me to say.
Any further comments on the evidence regarding this particular question? Okay, well, everyone cast your vote. Okay, so 13 is unanimous, 0 yes, 13 no. Thank you. Okay, so now we should move on to the benefits beyond health and special ethical priorities. The first question, so to help inform judgments of overall long-term value for money, please indicate your level of agreement with the following statements. The first statement, and it goes from 1 strongly disagree to 5 strongly agree. First question is, there is substantial unmet need despite currently available treatments.
So this is the table on, specifically addressing benefits beyond health and special ethical priorities. That's on table, it's table 16 on pages 15 and 16. For this particular voting question, a reminder, this is about the disease. The first couple of questions are about the disease. The second couple of questions will be about apitegromab itself. So is there substantial unmet need? We heard about the absolute shortfalls in QALYs and EVLYs, and that they appeared to be substantial, equivalent to childhood leukemia. And there was some discussion about mitigating that a little bit, depending on which population you want to think on. But I think most people would agree that there is substantial unmet need.
Everyone cast your vote. So 5 agree and 8 strongly agree. Okay. Thank you. The 6th question is, this condition is of substantial relevance for people from a racial or ethnic group that have not been equitably served by the healthcare system.
So unfortunately, the term we use, no evidence, is probably wrong. There is evidence that there's not significant differences in the prevalence of this condition across different race, ethnicity subgroups and other subgroups.
Anybody else have any comment?
I just have a question. So to make sure, in a case where we have evidence that there is no difference between different racial groups, I'm just trying to think, should my response be like neutral or disagree? Because I'm just really trying, it's similar, and I almost feel like this is neutral, it's not that there is benefit to some side. I just want to make sure I'm thinking about this right.
So we've been trying to rework both the question and the answers on this for these reasons. And we don't have a perfect answer on whether the correct vote here is neutral, or I would suggest the neutral one in this situation. If your position is that there is no difference, we hope to reword the question in such a way that that doesn't cause trouble.
Yeah, I think I was struggling with the same thing. I was leaning towards strongly disagree on that one, because there is evidence of absence of relevance in terms of racial or ethnic. So I was leaning towards, but I can go with neutral. I mean, I get it's the same answers coming across, the same conclusions coming across. Any others? Okay, everyone cast your vote. Next slide. 2 disagree, 11 neutral. Okay, the next couple of questions, the last 2 questions. To help inform judgments of overall long-term value for money, please indicate your level of agreement with the following statements based on the relative effects of apitegromab in addition to standard of care, either risdiplam or nusinersen, versus the standard of care alone. So the question is, or the statement is, the treatment is likely to produce substantial improvement in caregivers' quality of life and or ability to pursue their own education, work, and family life. So this has to do with the caregiver.
This is challenging. I think, I mean, there are some benefits, like there may be some benefits. We think there are probably the benefit, But there's uncertainty. You voted that there wasn't clarity on that the benefits outweigh the harms. But clearly, if there are benefits, that probably would reduce caregiver burden somewhat. But we also have the flip side of needing to go to an infusion center, and at least when we're talking about children, that's a burden on caregivers. So sort of a little bit of uncertainty here.
Timothy?
Yeah, just so I understand what we're being asked to vote on, it says the treatment, and you had the previous slide up there. Are we being asked to vote on a particular?
Yeah, these two are specifically about apitegromab. So the first
Okay,
two votes were
thank you.
about the condition, and this is specifically does the use of apitegromab, and we would have to think about in the population in which it was studied, have a substantial improvement in a caregiver's quality of life and or ability to pursue other things.
Thank you.
Portia?
Yeah, I just wanted to say, as far as the caregiver perspective, to think about how those really small gains, like being able to reach a little bit further, or can really impact a caregiver's quality of life, you know, to not having to be called to go and reach something for them, or to play on their iPad. My son's a massive fan of Roblox. You know, if he lost the ability just to do that, he wouldn't be able to play independently on his iPad. So those small gains do really impact carer quality of life, because it gives the child or the adult that little bit of extra independence.
Any other comments? Everyone cast your vote. So we have for question 7, 2 disagree, 7 neutral, and 4 agree. So that's a pretty split vote. So, okay. And the very last question that has to do with the relative effects of apitegromab. The treatment offers a substantial opportunity to improve access to effective treatment by means of its mechanism of action or method of delivery. And so, I guess, Jeff, I'll give you the.
Yeah, I mean, I think ICER's intent with this question was sort of to get at rural-urban divides a little bit and the disparities there, and take them away from the prior question about disparities. But the others can correct me if I'm wrong. But in this case, you know, we aren't moving from an IV therapy to an oral therapy that makes a big difference, improves access. Here we have something where you have to go to an infusion center, which even if you live in a city a couple of miles from an infusion center, it's a burden. My daughter goes once a week for an infusion, and it's a big burden on us getting her there and getting her back and stuff. So I think there's you know, there's certainly no improvement. In fact, it seems to go the other way if you're going to use it. But I will say, you know, the patient community, if it helps, as we heard from Portia, if there's even a small improvement, families will do that for their loved ones. But I don't think this is reducing burden.
Tim?
Yeah, I just want to be sure. Should I focus on the part of the question that says mechanism of action or method of delivery, and not be thinking of cost? Because anytime I think of access, my mind usually goes to cost. But we know we don't have. We're not voting on that evidence. Should I put costs in the equation?
Cost shouldn't be in the equation for this question. It really is about ease of access. This question is really aimed to get at situations where we're missing a benefit of a therapy, where the benefit really is around improving ease of access. And I don't know that that applies here, but we wouldn't want to include cost here, because cost often for any new therapy might interfere with access. That wasn't the intent of this question.
That's what I thought, David. I appreciate that. Thank you.
Kurt?
Yeah, I wanted to tag on to Rachel's earlier question about I recognize that the frequency of this compared to nusinersen is different, but is there any reason to say you could not give both of them on the same day, apitegromab as well as nusinersen?
I'll leave that to the experts. My guess is no, probably not a reason to not give them at the same time.
Also, recognizing we have a diversity of knowledge, the implications of giving an intrathecal therapy to a 1-year-old are very different from the burden of that is very different from the burden of giving an IV infusion to a 1-year-old and the possible need for sedation or anesthesia. But in terms of just doing it at the same time, we can ask our experts, but I can't imagine why you couldn't do it on the same visit.
I mean, as far as I'd have that question for the experts. Would you do that? Because typically, if you're worried about adverse effects, you don't like to give two things at the same time so that you can determine which one's causing the adverse effects. So would convenience be not a good enough reason to give them together so that, I mean, if you have an adverse effect, then which one do you stop? Any comments from experts? I mean, like, would you give these two together if it landed on the same due date?
Dr. Crawford may be frozen. And
Oh,
yeah, Dr. McMillan may have stepped away. So
okay. Okay, we'll move on. Sneha.
I think when I was looking at this question, my mind immediately went to adherence. And I'm not sure if that's a fair concept to apply here, but I do think there is something to be said about particularly, and I want to just acknowledge the rural urban aspect of this is, thinking about that in mind, but still about how I know for a lot of people in our community, taking oral therapeutics every day is a little bit harder to do than just to go in one time a month or one time every couple of months for IV therapy. And so I just wanted to add that in the equation that sometimes I don't know if the daily oral makes it easier, at least for adherence wise versus the intrathecal therapy too. So I'm not sure if, again, adherence is fair to bring in here, but I do think that there's something to be said about that for just, patients' day-to-day life, and especially for young people and children. I mean, I hear so many stories from our community, at least, that there have been like weeks that they've skipped their oral therapeutics just because it's hard to do at any age, particularly a young age. And I understand the caregiver has a role here too in SMA, but I just wanted to offer that as well.
Thank you, Sneha. Brad.
Maybe a question to the clinical experts or perhaps our patient advocates. What's the normal clinical outpatient clinical evaluation? Are they going once a month pretty much anyway? Or is this something that once you get stabilized, you're going every 6 months? If you're going monthly anyway, and one of them is going to be an IV infusion, it might not be that big a lift, but I really don't know.
Portia or Giles, can you, either one of you, speak to that?
Yeah, I can jump in there. In the UK, we go in for a review twice a year, so once every 6 months. I'm a massive advocate for collaboration in care because our specialist hospital is actually a 2.5-hour drive away. So it was music to my ears when they said that this could be done in the community. If community nurses could come and deliver these injections, that'd be great. My son has Spinraza. We go up 3 times a year. He's 8 now. He completely understands why he's there. We talk about it. He understands that it's essentially saving his life, and he is very, very good. He doesn't need any kind of sedation. It only takes 5 minutes. It's really quick, and there's no trauma at all for him. I know it's different for other children. If this injection could be done at the same time as that, so once we try and coordinate our Spinraza appointments with our reviews. Doesn't always happen. So we do have to go up to London quite a lot. If it could be timed with that, that would be great. But I would say the benefit would have to be very clear for us to do an injection once a month on top of the if it were, and when I say it has to be very clear, it could be those small things like, you know, being able to reach farther, being able to sit up for longer, being able to hold his head up easier. That would be a clear benefit to us and our family. So yeah, that's my perspective. Giles has anything to add to that?
Yeah, I suppose just a slightly different side of things that my twins were switchers, so they were on Spinraza and then moved to risdiplam. So in terms of having the oral medication, we do not have very many clinical visits in a hospital setting at all. Potentially every 7 to 8 months, maybe. So any additional change to that actually kind of goes back to where we were at Spinraza time, and that is a detriment to both the twins, you know, honestly, their mental health, about going to hospital all the time, etc., etc. So any other interventions that is a problem. Now, if it was in the home setting, potentially that would change significantly. And then going back to Portia's point, you know, are those extra points worth that intervention? Potentially. But again, it's all about the individual. It's all about the individual approach and what they feel is enough for them to have those gains.
I think that highlights just how individual it is. Like, it's so different depending on your perspective and your family situation and how well your children are tolerating things. I mean, we're about to go on a summer holiday. We had Spinraza 2 days ago, and to know that it's done and I don't have to worry about giving him something every day now for another 4 months is really brilliant for us. But it doesn't work for everyone like that, which is why it's so important that every patient should have choice of all the treatments available, so that you can do a plan that fits you and your family and your circumstances.
Right, well, thank you.
Doctors McMillan and Crawford, while you were away, a question came up about whether a patient could come in and get their Spinraza, their nusinersen, and get the IV infusion of apitegromab at the same visit, whether that would be okay, or whether because of some concerns you wouldn't want to deliver them together because of the potential for sorting out side effects or something like that.
Oh, you're on mute, Dr. Crawford.
I'm sorry for blinking out. I was on call last night. They were excluded in the trial because they didn't want to confuse AEs from one versus the other. But there's really no plausible reason why you can't combine the two.
Thank you. Okay, any other comments or questions?
Jill, can I just ask a follow-up question to that? The expertise that is needed for an IV versus a intrathecal is very different. So I think what we're trying to get at is will it make it more easier if we give it at the same time? I think for other issues, if a patient is going for an IV infusion center, I don't know that you do you do your intrathecal injections in infusion centers, or do they have to be in a different setting?
It differs. I have 2 9-year-olds who get Spinraza in a without anesthesia. They prefer it that way. Mother prefers, and we've trained them to do it. Many of the younger children require an anesthesia because you can't do a spinal tap on a moving target. But by the time people get older, for the largest group of them either get it in a conventional fashion or with interventional radiology because of bad backs and things like that. You're right. The difficulty, the doing an IV infusion is a lot easier, a lot different. Doesn't require any of the same thing. And in fact, I think the plans are that the vast bulk of the doses will be given at home by home infusions.
Dr. McMillan, did you have anything to add?
No, I have nothing to add in terms of the discussion that Dr. Crawford shared. I do echo what Sneha and Portia had said with regards to families and patients' choice about risdiplam versus nusinersen, it really varies tremendously. Some people will have very strong preferences of one versus the other because of the repeated anesthetics and how traumatic they are. Some people will feel much more in favor of having nusinersen so they can get it done and then not have to worry about it. I would say compliance with the daily medication, in my experience, tends to potentially become a bit more of an issue with the adolescents. Because if someone's feeling stable and someone's feeling fine, sometimes there's the risk that they could stop taking the medication, and there might be a period of time where the parents aren't aware of that. So I think there's challenges with both, and it's quite variable from one family to the other and one patient to the other in terms of what they prefer.
In that respect, it's a little bit similar to the anti-HIV therapy. So when people who have congenital HIV reach adolescence, more than a few people struggle with taking doses because they don't see it does anything for them until it doesn't.
That's a good analogy. Thank you. Okay, any other comments? Okay, everyone cast your vote. One strongly disagree, 7 disagree, 3 neutral, 2 agree. So we were more all over the place on this question, but thank you all. Thank you, patient experts, clinical experts, everybody. Thank you. This was a good conversation, and thank you for the voting. I think this concludes our voting session. So now we should go on break until 2 p.m. when the policy roundtable will begin and Sarah will moderate. Thanks again.